I'd say one of them would be pre-hospital blood, increasing its prevalence over the past 3 years. And then also the interaction of the workforce and what we see with workforce dynamics with those leaving and entering the field. Pre-hospital blood is a great new innovation that is really already starting to take an uptake in EMS care. We saw an increase from 5 to 10% over the past few years of ground ambulances giving blood in the pre-hospital space. But if we're not focusing on the workforce as well, then we might have all these great new interventions or abilities to give care to these patients. But if we don't have a workforce that's available to deliver that care, then we can have all the innovations in the world, but not really have anything to do with them. And so what I would really distill down is that we have all of this great care that we're delivering, but if we don't also focus on those delivering that care, then we're going to be in a tough spot regardless of what we're doing. So another big piece of this report, which I'm really proud of, is the workforce analysis. One, it shows that ImageTrend is working with a number of state partners to look at what really matters, the potential turnover, the potential instability that may be there within the EMS workforce. We can have anecdotal evidence all day long, but until we really get into the data and work with partners to look at their specific data, we're not able to really have an understanding of what's happening. And without knowing that, for instance, in this report, 25% of our licensed workforce in these 5 states left after 2 years, then we might not know the necessary scope of the problem. And if we don't know the scope of the problem, then we don't know how to intervene. And so when you dig deeper into this data, we see that there are differences in those entering the field versus leaving the field, both in gender and in educational attainment. This data informs a lot of the common discussions that we're having in the EMS space about education, about disparities in care, and a workforce that is reflective of the populations that we serve. In the report, we focus on the fact that we see 25% of our population potentially leaving after a 2-year period. And what that really shows us is the dependence that we have as an EMS system on the educational system. If we don't have competent entry-level providers entering the field, then we may not be able to replace those who are choosing to leave. Now, they're choosing to leave for a variety of different reasons, and that's a whole nother evaluation. But what we do know is that without a healthy and strong EMS educational system, we're not going to be able to stay a healthy and strong EMS care delivery system. So what we want to make sure that we do is not lose sight of the forest for the trees and recognize that it's not just clinical care, it's education, it's workforce, it's operations, and all of that supports clinical care and make sure that we're in the best place that we can be to support patients. I really don't think it's a surprise to many people that 60% of the calls in this report were classified as low acuity. In this setting, we really need to make sure that we are preparing our clinicians for the types of calls that they're going to be responding to, because really EMS kind of sits at the intersection of healthcare, public health, and public safety. We're all 3 of those things, and we ebb and flow between those designations pretty regularly. And so when it comes to low acuity calls, this is an opportunity to intervene on patient health where they may not have other avenues to enter the healthcare system. And so we may recognize that our responsibilities and the roles that we play as EMS agencies may be changing, and the education, the preparation, and the way that we think of ourselves as a profession may need to change with that. Whenever we think about behavioral health responses, we need to make sure that our clinicians are properly prepared to triage these patients, to treat these patients, and to honestly treat them with kindness and compassion that all of us deserve. What we recognize from the retrospective data is that almost 50% of calls that EMS clinicians say are behavioral health related actually are not dispatched as behavioral health. And so what we want to make sure that we're doing is that when our clinicians arrive on scene, whether or not they expect it to be a behavioral health complaint or not, that they have the education to know what tools to use, that they're prepared to use de-escalation strategies, and to really think about both patient and clinician safety. So we're seeing a lot of uptake of pre-hospital blood transfusion administration, and we're seeing that really in ground ambulances specifically, going up from 5% to 10% in recent years. And what that is really showing us is that this new innovation is already here, and it might actually be surpassing the science and the evidence that we have to show how effective it is. And so what we need to do as agencies, what we need to do as those that are immersed in that data, is to make sure that we don't stop innovating, that we don't stop collecting that data and evaluating what we're doing in the field to make sure that it's still the right thing for patients. Because in the end, that's what we're here to support, is reduce morbidity, reduce mortality, and better outcomes for our patients that we're there to protect. Agencies really should be thinking about these things now because we already have the rollout of these programs across the country. We have increased funding available from states and federal partners that are looking to support the rollout of this new innovation to support the health and the reduction of morbidity and mortality for patients in the pre-hospital setting. And so while you may not be interested or have the bandwidth to start a program right now, we're finding out what those best practices are. We're finding out what the evidence is to support why we're doing what we're doing and to figure out what the best way is to provide this care to patients in the pre-hospital space. So what we want to do is make sure that from an agency standpoint that we commit ourselves to excellence in pain management. And that comes from documenting that we give a pain assessment, that we give pain medication, and that we have all of the information about those patients documented correctly so that on the research side, when we look at proportional differences in pain medication delivery, that we know that that's what's really happening in the real world and not just data that may not represent the actual happenings. So, what's one thing from this report that I would act on today? And it's going to sound highbrow. It's going to sound like an overarching thought process, but it's data, right? Without data, we can't have evidence. Without evidence, we can't prove that what we do is any better than jumping into a taxi and going to the ER yourself. In this case, we want to make sure that we have the data to inform the evidence to inform our practice, and the evidence to defend our practices and what we do in the field, because we're there to help patients. We're there to reduce morbidity, reduce mortality, and to be there for patients on the worst day of their lives. And we want to make sure that we have the evidence to show that what we're doing works. And we can't do that without the data. And so we need to recommit ourselves to data collection, recommit ourselves to data quality, and recommit ourselves to making sure that we're placing ourselves in the right place at the right time with the right data to back us up to be there for our patients.